Dr. Yukut will now address the difficult issue of echocardiography in systemic disease. Because this represents a wide, broad spectrum of disease, she will just concentrate on two of them. First, systemic sclerosis and then lupus. She will show that we have to pay attention to morphological features and also functional parameters should be evaluated. She will also show us that we have to pay attention to the left ventricle, but also to valves and pericardial disease.
While the spectrum of connective tissue disease is quite large, I will present here the two diseases that are the most relevant for cardiologists due to the high rate of cardiac complications, and these are systemic sclerosis and lupus. Systemic sclerosis is a connective tissue disease characterized by the progressive fibrosis of the skin and also of the viscera, from which we are interested in the heart and the lungs. Pulmonary arterial hypertension is an important health problem in systemic sclerosis. This is because of its high prevalence of around 10 to 15% and the fact that it has a highly negative prognosis. It can be either a vascular disease, mainly in the limited form of sclerodermia, but also secondary to the pulmonary fibrosis. This is why a recent consensus of experts from 2013 asked for the implementations of program of annual screening of patients with systemic sclerosis for pulmonary arterial hypertension. And I will begin by showing you the case of a 60-year-old woman who was diagnosed 1 year before with scleroderma and a few months afterwards with severe pulmonary hypertension. This is very relevant because these patients can benefit from specific pulmonary vasodilator therapy. I will begin by showing you the most prominent feature of her 2D exam. From the parasternal short axis, you can see how her interventricular septum is flattening both in systole and in diastole due to a significant pressure overload of her right ventricle. This is an indirect sign and also is associated to the presence of pericardial effusion, which can be associated either to the systemic sclerosis itself or to the pulmonary hypertension, to which it can be associated and shows a worse prognosis. Now, looking for the direct measurements of pulmonary hypertension, we will look first at her pulmonary valve, where there is a moderate pulmonary regurgitation, allowing us to measure both proto and telediastolic gradients between the pulmonary artery and the right ventricle. These gradients measured here are allowing us to obtain measures of both the mean pulmonary arterial pressure and the diastolic pulmonary arterial pressure when adding the value of the right atrium pressure. Also, when we look at the profile of the RVOT anterograde flow, we can see that there is both a very short accession time, showing a high mean arterial pressure, pulmonary arterial pressure, and also an incisure on the ascending limb of this profile, also being a sign, an indirect sign of high pressures in the arterial vasculature of the lungs. We are also looking for a direct measurement of the systolic pulmonary arterial pressure, and for that we go to the tricuspid regurgitation from four-chamber view. We see here there is a moderate tricuspid regurgitation, which allows the measurement of a 90 millimeters of mercury gradient between the right ventricle and the right atrium, to which we need to add the value of the right atrial pressure as based on the dimensions of the inferior vena cava, which is 19 with little inspiratory collapse, showing us that the pressure estimated by echocardiography is around or above 100 millimeters of mercury. To this is associated the presence of a very large right ventricle with a visual impression of right ventricular dysfunction, which we can confirm not only by looking at it closer, but also by measuring the systolic peak velocity of the tricuspid annulus in myocardial pulse wave Doppler, which is 9, being below 11, showing a dysfunction of the right ventricle, and also by TAPSE, which is of 15 millimeters, again decreased. So this shows the case of a patient with severe pulmonary hypertension associated to scleroderma and leading also to a depression of the right ventricular function. However, this is not the sole complication in patients with systemic sclerosis. One of the other features of the disease is myocardial fibrosis. This can be found in pathologic examination in up to 80% of patients. However, overt systolic LV dysfunction is only present in different studies in up to 5% of the patients. And this is a case of a young 39-year-old woman with systemic sclerosis known for several years who came to our department for dyspnea at minimal exertion. When beginning the echocardiography, we can observe from the very beginning that the ventricle, which is not dilated, having a diastolic diameter of 50 millimeters, has an obvious left ventricular systolic dysfunction, both global, and we will go to this also in the following measurements, and also regional. Here we can even see a region of some hyperechogenicity, which may make us think that there is also a coronary artery involvement. Again, pericardial effusion, characteristic to connective tissue diseases as an association. When we go to a short axis, we see again the global left ventricular dysfunction, which with some flattening of the interventricular septum only in diastole, indicating the possibility of right ventricular volume overload this time. Also, from a four-chamber view, we can observe the presence of a global left ventricular dysfunction, and we can measure the left ventricular ejection fraction in different ways. Of course, the best, the biplane Simpson, and also by automated measurement of the ejection fraction, we obtained an ejection fraction of 29%. In this patient, moreover, there was an association of a dysfunction of the right ventricle, which is enlarged with the lack of coaptation of the tricuspid valves, with an important severe tricuspid regurgitation, showing a gradient between the right ventricle and the right atrium of 28 millimeters of mercury, indicating that even in the presence of a large orifice between the right ventricle and right atrium with a sort of free tricuspid regurgitation, we cannot indicate the presence of pulmonary hypertension, but we have to confirm this by other methods, like, for example, the pulmonary artery ascension time, which is above 100 milliseconds with no incisure on the ascending limb, and also by looking for possible gradients in based on the pulmonary regurgitation, and these gradients were in this case small, of 10 and 5 millimeters of mercury respectively. So this is a case of a patient with important LV dysfunction, and of course we had a coronary angiogram performed for this patient, and the epicardial coronary arteries were completely normal, while cardiac MRI confirmed the presence of patchy late gadolinium enhancement in the whole of left ventricular wall, so diffusely, not respecting a coronary territory, showing that there is probably just myocardial fibrosis attached to, associated to systemic sclerosis. Now, going to lupus. Lupus, systemic lupus erythematosus, as it is correctly and completely known by rheumatologists, is an autoimmune disease which can involve different organs, from which the heart and the lungs again can be involved. And here is the case of a 25-year-old woman who was addressed to our department for dyspnea, which was installed for several months now. From the first images, we can see that the impression is of a normal dimensions left ventricle, but an enlarged right ventricle. And this is also confirmed by the short axis view with flattening of the interventricular septum, and by the apical four-chamber view with an enlarged right ventricle with a somewhat smaller left ventricle. And indeed, in this patient, we found by interrogating with continuous wave Doppler the tricuspid regurgitation, which was, by the way, mild, we found a gradient of 70 millimeters mercury between the right ventricle and right atrium, confirming the presence of pulmonary hypertension, which was then confirmed by pulmonary artery catheterization. Actually, lupus is the second cause among connective tissue diseases for pulmonary hypertension. So it also should benefit from screening programs in these patients. Another feature of lupus is valve thickening and valve disease. We can see valve disease in up to 50% of patients with lupus. This can be of no hemodynamical importance at the beginning, and it can occur in all valves, but mainly in the left heart and the mitral valves, causing mainly regurgitations. Here you can see the example of a 38-year-old woman. Generally, the age of onset of lupus is in early adulthood in women, statistically, who presented with symptoms of heart failure of NIHA class 3 at the end of her pregnancy. And based on her echocardiography and afterwards on her laboratory workup, including immunological tests, the diagnosis of systemic lupus erythematosus was posed. And you can see on her echocardiography that her mitral valves are somewhat thicker and they don't open fully. When measuring the thickness of the distal part of her anterior mitral valve, this was of 3 centimeters and somewhat hyperechogenous. And when interrogated by color Doppler, we can see there is mitral regurgitation, which is also confirmed by in the four-chamber apical view. And you can see here, this is a significant mitral regurgitation. Moreover, there was an association of discrete thickening of the free margins of the aortic valves, which are tricuspid, leading to a degree of a mild aortic stenosis by planimetry and also by continuity equation being around 1.9 centimeters square, which shows us that this patient has the involvement of 2 of her left heart valves. Another feature that is quite well linked and known with lupus is the presence of the Liebman-Sachs endocarditis. This is characterized by the presence of vegetations which are at first non-infective on any valve, but more frequently on the valves on the left heart. It is said to be more frequently associated in cases of lupus where also antiphospholipid syndrome coexists. And this is the case of a young 16-year-old girl who presented for fever for several weeks now and symptoms of heart failure. She was known to have lupus for several years at that point. And on her mitral valve, we could see a mass which was quite large. It was present on the anterior mitral valve, which was also nicely confirmed in short axis of the mitral valve. You see it is located on the middle scallop of the anterior valve, and which impended on the closure of the valve and gave, in this situation, significant mitral regurgitation. In this case, of course, we need to make a differential diagnosis between the Liebman-Sachs endocarditis and an infective endocarditis, which can actually complicate the Liebman-Sachs endocarditis. Another observation in this patient, for which the apical views confirm the existence of the mitral regurgitation with an eccentric flow, is that In her right atrium there is a mass, and actually when she had surgery for her valve pathology, this mass was removed and proven to be a thrombus. The presence of intracardiac thrombus in patients with antiphospholipid syndrome is also a possible finding, usually appearing incidentally and asymptomatic, but also possibly associated to peripheral or pulmonary embolus. All these changes put the patients with lupus at high risk for cardiovascular complications, and indeed these patients benefit from the integrated approach of rheumatologists and cardiologists.
So a key point is that we have, of course, to look at the left ventricle, to valves, pericardium, but also to the right ventricle. And moreover, it's very important to keep in mind that sometimes it's quite obvious. We have a very typical feature, but sometimes it's not so obvious. So the diagnosis should be done with the context, especially the clinical context and biological context.